great data. The two authors said that they're biased, but I think I can also say that I'm not involved in either trial, that they're really clinically highly meaningful data for our patients. You saw by Dr. Sledge the 50 months to chemotherapy. This is a game changer in metastatic breast cancer. But let's take one trial after the other. The MONARCH 2 trial shows for the first time a significant overall survival advantage in a purely second-line cohort of pre-postmenopausal patients. It's the first time we see overall survival data for abemaciclib, which is one of the three CDK4/6 inhibitors, and the delta of 10 months is really clinically meaningful, but also the 46 months patients live with their metastatic disease in the second line with abemaciclib. MONALEESA-3, as Dr. Slayman pointed out, sort of rounds the data for ribociclib. It's a postmenopausal study, but they presented earlier another trial at ASCO this year for the premenopausal patients. And MONALEESA-3 for the first time gives us now data in the first and second line setting, so patients who have not been receiving any endocrine therapy before that, and that makes it also highly clinically meaningful because we were always struggling with whether to give these drugs first or second line, and I think now we can see there's a first line survival benefit. I think that should be the new standard of care of CDK4/6 in the first line setting. So the data are highly clinically meaningful. I think they're going to make a huge impact in how we treat metastatic breast cancer. It's a disease where the epidemiological registries give you a median of 2.5 years median survival. And here now you saw in the MONARCH 2 study, which is a slightly later line of therapy, 46 months median survival. That means half of the patients even live longer. And with the MONALEESA-3 data, we didn't even see the median because the patients are doing so well, but the control arm was at 46 months. So you can see that that is stretching out quite a bit. So I think the data will make sure that these drugs are going to be standard. They're going to be, should be, in my opinion, first line standard in the metastatic setting, because you can never guarantee that a patient comes back for a second line of therapy. They may be too sick, they may not want to come back, so we should give the best drugs first. And the overall survival differences are also meaningful for access to these drugs, because some of the health technology assessments in individual countries around Europe do require overall survival for reimbursement. So this data is going to change that. And lastly, and I will stop there, Dr. Slayman was one of the pioneers of the HER2 story, and he cannot say that, but I think that these drugs will be a similar success as the HER2 story for our patients with hormone receptor positive breast cancer. And these drugs will need to be explored, and they already are doing that in the early breast cancer setting, because there we cannot just prolong survival but reach cure. And these trials will hopefully reach out and be presented in the next year or two, and hopefully also at the ESMO meeting. Thank you very much.